Okay guys, welcome back. Let's keep doing this. So now we are going to speak about renin. Renin is secreted by the juxtaglomerular cells. And can someone tell me, are these in the proximal tubule or are they in the distal tubule? Speaking about the juxtaglomerular cells, are they in the proximal convoluted tubule or are they in the distal convoluted tubule? No, they are neither in the proximal or the distal, they are in the mesenchyme. Yep. So in response, the renin is released in response to decreased renal perfusion pressure, yeah, which is detected by renal baroreceptors in the afferent arteriole. See, the moment you understand the material, you just have to read. You don't need to memorize anything. It all makes sense. Or due to an increased renal sympathetic discharge, the beta-1 effect, and also reduced sodium chloride delivery to the macula densa. Where is macula densa located though? DCT, excellent job. Okay, good. So the next thing is angiotensin II. It helps maintain blood volume and the blood pressure. Yeah. So, and it affects baroreceptor function, limit reflex bradycardia, which would normally combines its pressure effect. You know, when someone has like vasoconstriction, normally he has a bradycardia, like it just concomitant, you know. But in case of angiotensin II, it can also depress that as well. So the patient get 2 in 1. Yeah. The next thing is something like this. It's A and B and B and B. A and B and B and B are secreted from which organ? The heart. Can someone tell me what type of secondary messenger is activated in case of A and B and B and B? The cyclic Gmb, that's excellent. Okay, good. So, yeah, so cyclic Gmb. Good, so it's released from the atria and the ventricle in response to increased volume. If you did not know that, it's okay. You will see that in endocrinology. It's not in cardiology even. It's mentioned a little bit in cardio, but mainly it's in endocrinology. So the increase of A and B and B and B inhibits the RAS system basically and relaxes vascular smooth muscles via cyclic Gmb, which increases your GFR. Why? Because you will have more afferent arteriole vasodilatation, which increases the amount of the blood coming to your glomerulus, which increases the GFR. It also promotes natriuresis, so more sodium will go outside of your body. Is this a good thing in a patient with heart failure? Yes, it's an amazing thing. More sodium coming outside of your body means less volume. Less volume, less preload. Less preload, less cardiac demand for O2. Less cardiac demand of O2, well, you will not die. It's good. ADH primarily regulates serum osmolality, also responds to low blood volume states. So when you have a low blood volume states, your ADH will be hyperexcreted, which will lead you to having a better amount of regulation of the water inside of your body. They stimulate the reabsorption of water inside of the collecting tubule, utilizing what? The aquaporin. So the ADH also famous question. In the collecting tubule, which cell does ADH work at? Is it the principal cells, alpha intercalated cells, beta intercalated cells? Principal cells. Yes, ADH work at the principal cells. It also stimulates the reabsorption of the urea in the collecting duct to maximize the corticobabillary osmotic gradient. Now guys, I'm going to tell you an exact question that came on the steps, and I want you to master it, okay? The collecting duct itself consists of two portions, okay? So this is just the collecting duct, nothing else. And it has two portions. The first portion, we say the cortical portion of the collecting duct. The second one is the medullary portion of the collecting duct. The urea absorption happens at the medullary portion. Okay, so the question was where urea get reabsorbed. It's true that it's in the BCT, but also it is at the medullary portion of the collecting duct. There was a choice as a cortical portion and a choice as the medullary portion. It's the medullary portion. The reabsorption of urea happened at the medullary portion. I saw this question on the Real Deal. I saw this question in multiple MBMEs in New World, and you are going to see it today on one test after the class. So you should know that urea reabsorption happened at the medullary portion of the collecting duct. Okay. Next. The next question is about aldosterone. It primarily regulates extracellular fluid volume and sodium content. Increased release in decreased blood volume states. Okay, so response to hyperkalemia by increased potassium excretion. So we spoke how aldosterone can directly work in the BCT, increasing the sodium reabsorption. We also spoke about how aldosterone can work on the DCT, on the collecting duct, and leads to more potassium excretion, more hydrogen excretion. If you have more hydrogen excretion, will you get an alkalotic state or an acidotic state? Excellent. Yeah, contraction alkalosis. Excellent job. Yeah, so that makes sense. So the next thing we are going to speak about is the juxtaglomerular apparatus itself. Okay, by the way, what does the word juxta mean? I will, just a second, after I explain this thing, not the whole thing, just the name, I will go back to speak about the aldosterone escape mechanism. So can someone tell me what the word juxta mean? Juxta in Latin means like next to or near something. It's near it. So juxtaglomerular, it means it's near the glomerulus, near the glomerulus. So juxtaglomerular apparatus, it's the apparatus, which is the like the system near the glomerulus. Okay. So let me speak about the aldosterone escape mechanism, since it's super important and you must know it. I explained it once in CVS. I will explain it now in renal. I will explain it again in endocrinology. So you just have to get it once. Speaking about the aldosterone escape mechanism, when your aldosterone is super high, what happens to the sodium level? Like normally, think about it logically. The reabsorption of sodium, does it increase or decrease with aldosterone? Yes, it increases. You have more sodium going back to your body in case of aldosterone because of its function on the principal cells, yeah? So more sodium reabsorption. What about potassium? Potassium is secreted more outside. So guys, when you have more sodium inside of the body, what sodium likes? Water. Yes, it likes water. So more water will go back inside of your body. If you have more water inside of your body, you will have it inside of your system as well, like inside of your vascular system, inside of your circulation. That will lead to overstretched your ventricles and atrium of the heart. So which substance is going to be released? If yes, there will be an increase of AMB and BMB. These will lead to natriuresis, and natriuresis means basically like a lot of sodium will be excreted inside of the urine. But notice, The potassium is not touched. You did not touch the potassium. So this patient will have normal normal sodium level. Why? Because yes, it's true that you had initially more sodium, but because of the aldosterone escape mechanism, there was natriuresis which have decreased the sodium, leading to normal sodium level. But this patient will still have hypertension. Okay, they still have hypertension because of the freaking angiotensin II working. Okay, and in the same time they have hypokalemia. Why? Because the hypokalemia is secondary to what? The potassium secretion outside of the body. So if you see a triad of normal sodium level, hypertension, and hypokalemia, think about hyperaldosteronism with secondary aldosterone escape mechanism. The aldosterone escape mechanism basically means that the patient, yes, it's Cohn syndrome, the patient has like a lot of aldosterone, but he has a normal sodium. And the question is why? And the answer is because of the increase of the atrial natriuretic peptide and the brain natriuretic peptide. Let's keep going. Juxtaglomerular apparatus consists of mesangial cells, and juxtaglomerular cells are modified smooth muscles of the afferent arteriole, but they are not inside of the afferent arteriole. Do not make that mistake. They are outside of it. Okay. And the macula densa is a sodium sensor located in the distal end of the lobe of Henle, or near the DCT basically. And the juxtaglomerular cells secretes renin, which is an enzyme, in response to decrease the blood pressure and increase sympathetic tone. And also macula densa cells sense the sodium delivery to the DCT, and when it is decreased, you will have more renin release, and that more renin release can lead to efferent arteriolar vasoconstriction, and that will increase your GFR. So the juxtaglomerular apparatus maintains the GFR via the RAS. How? By vasoconstricting the efferent arteriole. Okay? Actually, the macula is like most textbook write in the DCT. Even in UWord, they write in DCT. Okay? So even here, look, macula densa cells senses sodium delivery to the DCT. I get it. There is actually, it gets kind of confusing what they wrote here, but yeah, just know that it's in the DCT. Forget about this lobe of Henle thing. It sounds fishy. I will look it up and write in the group actually, because this sounds fishy. I'm pretty sure that it's in the DCT, because like there is multiple UWord question about it, and even a couple of AMBUS question. I will look it up and write for you for sure, guys, to be more comfortable. Okay, excellent. So somebody confirmed from the okay. Yeah, that looks more located at the DCT. That looks more realistic. Yes, excellent. By the way, guys, I got a new laptop, so from next class I'm going to be using the new laptop. My new first aid will be there, first aid 2021, and that will be starting to do that from the other laptop. So like the problem with the delayed editing, it happens because this laptop is kind of slow, so it takes me all night to do that. But with the new laptop I will be able to do that much more faster, so you will have your lectures recording in time. So juxtaglomerular apparatus maintains GFR via the RAS system. In addition to vasodilatory properties, beta blockers can decrease the blood pressure. So how does the beta blocker decrease the blood pressure? Well, multiple mechanisms. The first mechanism is by the inhibiting of the beta 1 receptors located at the juxtaglomerular apparatus, which decreases the renal release. Less renin, less RAS system. Less RAS system, less aldosterone. Less aldosterone, less blood pressure. Okay. Decreases cardiac contractility as well. Less cardiac contractility, less stroke volume. Less stroke volume, less systolic blood pressure. Less systolic blood pressure, well, that's it. What do you want more than that? It's enough. Okay. The next thing, The kidney function include the three things. So, reabsorption, filtration, and actually more. Reabsorption, secretion, and filtration, and endocrinological function. Okay? So the endocrinological function, starting with the erythropoietin. They love this question. Where is erythropoietin released? No, they will not ask you, is it from the kidney? They want you to know the exact cell. It's released from the interstitial cells of the pretubular capillary. You are like, wait. What is this pretubular capillary? Well, if you remember, we had the afferent arteriole, then the glomerulus, then the efferent arteriole. After the efferent arteriole, we had another structure. That structure is called the peritubular capillary. The peritubular capillary is basically a network of capillary that is covering your whole tubules. Okay, so that's the peritubular capillary. It's a network of capillaries that are covering the whole tubules. I hope it makes sense. Okay. So and if we speak about the erythropoietin, it's released from the interstitial cells located there. And if they ask you what has like stimulated it to happen, you must say it's the what? It is the hypoxia. And in the future, when we do hematology, we will be telling you exactly how the hypoxia lead to this. It's actually interesting, but this is for the future. The erythropoietin stimulates RBC proliferation inside of your bone marrow. Okay, and it can be administered for anemia secondary to chronic kidney disease. Okay, why? Because in chronic kidney disease, the cause of the anemia is decreased in the erythropoietin, so you just give it. But it increases the risk of hypertension. Why this is important? I'm going to give you a typical USMLE step 1 case and step 2 actually. They give you a story about a cyclist, okay? A cyclist or a person who do a lot of exercise, like they go and do a lot of sports. And they come to you and tell you, oh, this patient, he's a 24 years old cyclist or gymnastics, and now he has hypertension and his hematocrit is crazy high, like 55 or 60. In addition, he's going to run a marathon tomorrow. So what's up? He has polycythemia. Why? What did this guy do? He consumed erythropoietin. There is a process called doping. Okay, it's called doping, in which there is a recombinant form of erythropoietin that we give for patients with chronic kidney disease. It's available illegally in some like drug. I don't know where you can find that, but basically it's like a drug. They consume it. Why they consume it? Because when you have more blood, you have more oxygen carrying capacity, so you get tired less often. When you get tired less often, you can run the whole freaking marathon without gasping for breath. So that process is called doping. It's not that bad, you know. You will just get hypertension and the high possibility of Cayeris Syndrome. Oh, guys, are you hearing me clearly? Wait a second. Can you guys hear me? Okay, that's bad. Let me try something. Can you hear me now? Oh, okay, that's good, that's good. So I was speaking about the process of doping. Did you hear me speaking about that, or I was cutting off? Okay, so in the USMLE, they like to mention a process of doping. What is doping? Basically, they mention for you a patient with hypertension, okay? They come to you complaining of headache, stuff like that, and you check his blood pressure and it's high. After that, you are like, okay, can you tell me, please, what are you up to? And he tells you, well, tomorrow I have a marathon and I'm a cyclist, like I ride bike a lot. And I like to work out a lot, like I work out 7 times a week. and you see him to be highly muscular. Okay, it's not anabolic steroid, do not get it tricked with that one. So basically, what's wrong with this patient, that he's consuming a lot of erythropoietin. He's injecting himself with erythropoietin. And when you inject yourself with erythropoietin, you get polycythemia. And when you get polycythemia, you have a lot of RBCs. Oh, see? Apparently swimmers do it as well. So you get a lot of RBCs. So you have more oxygen capacity on the RBCs. So you will not get tired. You will not get gasping of the breath. You will just keep going. And you will have much higher performance. Sounds perfect, yeah? Not really, because it will lead to polycythemia. Polycythemia can lead to two problems. Well, many problems, but the two main problems that are super serious. Problem number one, hypertension. Problem number two, Cayeris Syndrome. What is Cayeris Syndrome? Exactly, Cayeris Syndrome. Yeah, so what is it? Basically, if you have your liver has the portal vein coming into it. Yeah? Also, it has the hepatic vein. It has the hepatic artery. And what is coming outside of it is the hepatic vein, which goes to the IVC. Yeah? Inferior vena cava. So the hepatic vein is super interesting. Why? Because when it gets occluded because of the increased viscosity, lead to blockage of the hepatic vein. Why you have more increased viscosity? Because of the polycythemia. Why polycythemia? Because of the doping. Why the doping? Because I have no idea why he took that erythropoietin. So he get hepatic vein occlusion, and then what happens? Blood is entering the liver, but it cannot exit. Yeah? So the blood start accumulating inside of the liver, so you get an hemorrhagic infarction of the liver. Yeah? Hemorrhagic infarction of the liver. Yep, also called red infarction. Exactly. So take a look at this. Lovely. See? It's all red. It's all blood. Okay. So next. That was doping. Okay, calciferol. Calciferol, vitamin D. You are like, what brings vitamin D to the kidney? Isn't that from sun? Well, sun relate to this one, but it's not the only. Can you repeat BBS? What is BBS? So again, repeating about Cayeris syndrome, you mean? Are you asking about Cayeris syndrome or the doping? Person who was asking, Cayeris syndrome or doping? Okay, so really quick, starting about the doping. Okay, so doping. What is the idea of doping? The doping is like there is this substance called erythropoietin, which is normally released from the kidney. Okay, so it's normally released from the kidney. Now, what is happening that instead of it being released from the kidney, this person who's a cyclist, okay, this cyclist or like somebody who do any form of sport, they are taking it as a drug. Yeah. So they take it as a drug, the erythropoietin. So they get what? Well, the erythropoietin normally is responsible for erythropoiesis, which is making of RBCs. So your RBCs count is going to go up. Yeah. So when the RBCs is up, what happens next? RBCs is up. Next step that you go and have polycythemia. Polycythemia is basically a state when you have a lot of RBCs. Polycythemia lead to Cayeris syndrome. Cayeris syndrome, what is it? If you have your liver here, and liver normally have two connections into it. You have the portal vein coming in, and also you have hepatic artery, okay? And you have one vessel coming outside of it, which is the hepatic vein. Hepatic vein, after it leaves your liver, it enters something called inferior vena cava, okay? So when the patient has polycythemia, think about it. Is he having more viscosity of his blood or less viscosity of the blood? More viscosity of the blood. Yes. So he's having more viscosity of the blood. If you have more viscosity of the blood, what happens to the resistance inside of the vessel? More viscosity, more resistance. Yeah? More viscosity, more resistance. Okay. What is going to happen to, if you have high viscosity, also you have high risk of coagulation. Yeah? Coagulation and thrombosis. So a lot of RBCs will be like just coagulating inside of this vessel, which will lead to blockage of this vessel. So this vessel will be blocked. And next, what happens? The portal vein and the hepatic vein are totally intact. So the blood will be able to enter freely from these. But can he exit the liver from the IVC, from the hepatic vein, I mean? Can he exit? He cannot exit. So the blood is just coming in, but he cannot go out. So there will be an accumulation of the blood inside of the liver. Yeah? So blood, you get what? Red infarction. Yeah? Why? Because the blood is accumulating in. He's not able to get out. So the tissue will be full with the blood, which basically kill him. Yeah? So you get this red infarction of the liver. Other organ that also has this is the testicles. We have testicular infarction that exactly look the same. Okay? In testicular torsion, the patient can have red infarction. Notice the surgeon is like removing a testicle that have hemorrhagic infarction. Why? Because this happened, torsion. In torsion, normally what do you have? You have your spermatic veins like to the outside and the testicular artery to the inside. So when this testicle has it twisted on each other, the artery is intact, but the veins has been compressed. When they have been compressed, the blood has kept flowing to the testicles, but it cannot go out. If it cannot go out, that's a problem. You will get hemorrhagic infarction. I hope it makes sense. So, okay, let's keep going. Okie dokie. So, calciferol, it's vitamin D. So BCT converts the 25 vitamin D to 125 vitamin D3. So which one is the storage form and which one is the active form? The storage form is the 25 vitamin D, and the active form is the 125. So if we speak about the storage form, where is it stored? Which organ is stored? The liver. Excellent. So the 25 vitamin D, which is also called calcidiol, di, it means 2. It's converted to calcitriol, which is the 125 D3, which is the active form. And that happens due to 1-alpha hydroxylase that will be really important when we speak about tuberculosis and all of the processes of granulomas. Because granulomas, lymphoma, all of them have 1-alpha hydroxylase, which lead to conversion of the calcidiol to calcitriol, which lead to hypercalcemia. Keep in mind that the 1-alpha hydroxylase can be activated by PTH. Yeah? Okay. So now we speak about the prostaglandins. The prostaglandins is it's a baracrine secretion that vasodilates the afferent arteriole. If your afferent arteriole is dilated, what will happen to your renal blood flow? It will go up. Yeah? But here is the catch. If your renal blood flow, well, it's going up because basically it's your afferent arteriole is dilated. So if you use aspirin, your afferent arteriole will be constricted. This is one of the causes why, well, Tylenol is not a good idea. So NSAIDs block the renal protective prostaglandin synthesis, which lead to constriction of the afferent arteriole, which decreases your GFR. Basically, when you use a lot of NSAIDs, you will have less renal plasma flow, which can kill your kidney. This may result in an acute kidney injury in the low renal blood flow states. So basically, what I'm telling you now is that if this is our afferent arteriole, this is our glomerulus, and this is, yeah, because paracetamol works directly, that you are kind of correct, but it's hepatotoxic still. But overall, NSAIDs like aspirin, for example, or indomethacin, they vasoconstrict this guy. So that decreases the GFR. And that decreases the amount of the renal plasma flow. And that can basically, in different words, kill the kidney. Why paracetamol can be fine in this case? Because it works centrally, directly on the brain. Okay? So dopamine, the last one. It's secreted by the BCT cells, which promote natriuresis. To give to healthy baby. When taking NSAIDs, well, you know, when taking NSAIDs are the best to give to healthy patient. Healthy patient does not need NSAIDs, man. Oh, which NSAID should you give for a healthy patient? Well, look, you have it depends on the thing. Like headache, for example. Look, paracetamol will do it, but not so often. You know, actually, if someone has headaches and really headaches that keep happening and so often, like every single day, he's having headaches, and you keep giving him paracetamol, he's going to have an analgesics induced headache, which means if he does not take the analgesic, he will have headache, you know, which is really bad. Actually, you make him addict for this. For fever, it's always paracetamol, don't think twice. But for actual headache, if it was a little bit worse, instead of paracetamol, you can give ibuprofen. If it was, but let's speak about pain, okay? For pain, you need to give a different drug. If it was a bone pain, for example, a back pain, you can give diclofenac sodium, okay? If it was menstrual pain, like ladies with menstrual pain, you can give indomethacin or spasmolytics. If it was someone with a PDA, you give indomethacin. Someone with gout, you give indomethacin. Someone with an MI, you don't want to give NSAIDs, so you give what? Morphine, okay? You already gave an NSAID in case of MI, which was the aspirin. So you need to give a more strong drug, because in case of MI, the pain from 1 to 10 is more than 4. So you need to give a stronger drug like morphine, for example. Remember also that you have two types of opioid. That's according to the pain scale. You have a weak opioid and a strong opioid. The strong opioid are short-acting. The weak opioid are long-acting. This is all step 2 material, guys, but still, this is just an overview of the step 2 material. You don't need to know this for step 1. For step 1, you just need to know that NSAIDs constrict your afferent arteriole. That's what is required from you. Okay, dopamine. It's secreted by the BCT cells, proximal convoluted tubule, and they promote natriuresis at low dosages. It also dilates the interlobular arteries, which eventually lead to your afferent artery and efferent arterioles to be dilated. That means your both of your renal blood flow, what will happen to your renal blood flow? It will become ridiculously high. Yeah? But your GFR will be normal. You'll be like, why? Well, it does not make sense. Why the GFR is normal? Well, you have vasodilated the afferent and you have vasodilated the afferent. So the blood that you got in here, you also got out from here. So the GFR was the same, kinda, yeah? So mostly they tell you the GFR will be little or no change of the GFR, because whatever you got in, it went out. At higher dosages, dopamine can become a vasoconstrictor. Why? Dopamine initially acts at the D receptor. If you increase the dose, it starts acting at the beta 1 receptor. If you increase the dose even higher, it starts acting at the alpha receptor. So look at the word dopamine. D, D1 receptor, P for beta receptor, and A for alpha receptor. The more you increase the dose, the more the difference the receptor it works at. Guys, by the way, this is just a question I saw the other day, and it was actually kind of really interesting. Beta 1. And I actually want to ask you about it. If someone has Parkinson's disease and you are giving him levodopa, why do you think patient on levodopa, which vitamin is contraindicated on him? Which vitamin you should not give for a Parkinson patient? No, it's not vitamin D. Come on, somebody think. Somebody telling me to wait. How dare you? Okay, I will think. Okay, I'm giving you 10 seconds. 10, 5, 4. Okay, it's a B vitamin. Come on. Well, I will tell you like this. It's a water-soluble vitamin. Actually, someone got it, but I'm not telling whom. No, it's not the B9. Okay, let me show you guys. It's in the book, but it's hidden somewhere, okay? So it's actually hidden really good. I have to say, like, when I saw the question, I was like, what the hell? And then I understood why they asked it, because it exists in the book. So here it is. Just a second. So basically, if we speak about this, take a look. The DOPA is converted to dopamine, and the dopamine is converted to norepinephrine. If you have a patient who has Parkinson's disease, would you like him to have more dopamine or less dopamine? More dopamine. So if you give him a lot of vitamin C, will he have more dopamine or less dopamine? So is it a good idea? See? So no, it's a really bad idea. Look, if someone has Parkinson's disease, you want his dopamine to be elevated. If you give him vitamin C, this dopamine will be converted to norepinephrine. It's a bad idea. You want to increase the dopamine, so you restrict his vitamin C. You tell him, listen, do not take more than the required dose of vitamin C every day. Why do you actually care about that? Because currently, sadly, many pharmaceutical companies tell you, take the mega dose of vitamin C. Instead of taking 1000 milligrams, our dosages contain 6000 milligrams. So you are like, okay, screw you guys. So yeah, that's really bad for Parkinson's disease patient. Okay, just keep that in mind. I saw it like in one question and I did not know it. I had to look it up. So for you to know it for the future. And keep in mind that vitamin C is a water-soluble vitamin. That's also important. Okay, so the next question is, the next topic. Okay, now we are coming to more interesting portion of the book. We have the following: hormone acting at different section of the nephron. First of all, atrial natriuretic peptide. It's secreted in response of increased atrial pressure because of the stretch, if you remember, which lead to an increased GFR and increased sodium filtration with no compensatory sodium reabsorption in the distal nephron, which means it basically says that there is more GFR released from the glomerulus. Why? The afferent arteriole is being dilated. Also, natriuresis is being induced. Yeah? So, this patient with hyperaldosteronism, for example, they have reabsorption of sodium. And the A and B lead to excretion of sodium. So that will lead to a normal amount of sodium. Yes? So that is basically called, in another word, the aldosterone escape mechanism. Yeah? So the next thing I'm going to tell you about is the angiotensin II. It's synthesized in the response to decreased blood pressure and causes the efferent arteriole, this guy, to be constricted, which increases your GFR and filtration fraction, but with compensatory sodium reabsorption in the proximal and the distal nephron. Okay. So what is the net effect? Preservation of the renal function. What does it mean? Like when you constrict the efferent arteriole, your GFR goes up. When your GFR goes up, your filtration fraction goes up. Because remember, the formula for filtration fraction is GFR divided by the renal plasma flow. So the higher the GFR, the higher the filtration fraction. In the low volume state, with a simultaneous sodium reabsorption, both proximal and distal, to maintain the circulating volume. What does that mean? They are telling you that the angiotensin II, basically one of its function is to reabsorb the what? The sodium. Take a look here. Angiotensin II is working here by increasing the sodium reabsorption and excreting a lot of hydrogen outside. In the same time, on the collecting tubule, the angiotensin II is working, but indirectly. How indirectly? By functioning on the by inducing the secretion of aldosterone. The aldosterone will bind here, which also will reabsorb the sodium and excrete the potassium, and also do what? A hydrogen, kick the hydrogen out. So that's also important. And the next thing we are going to take a look at is here. Okay, so here I will stop for a second for a break, and then we will come back, finish these couple of pages, and I will make a poll during the break for you to choose between two topics because we cannot do both of them. And yeah, see you in 10 minutes, guys.